Good evening, everybody. I think we are a little bit late in the day, so I will try to be a little bit short, if possible. I would say that 20 years ago, it would have been possible to say there is nothing, and it will have finished the talk. But now it's a little bit more complicated. So I would like to go a little bit in the detail of my presentation now. So you know that this begins to be the past. It is FOLFIRINOX, and we have already seen all the data. We are treating patients with FOLFIRINOX. That is a little bit aggressive but active treatment. And we were very happy when we saw the results of nab-paclitaxel in combination with gemcitabine. It has already been presented into the large details, so I do not want to go back on that. And I think it's a new option for the patients, and also a very active regimen, as it has been proven by the improvement of overall survival. And we have to keep in mind the fact that there are, and I don't want to show you that, but there are more than 20 randomized trials showing completely negative results when patients with metastatic pancreatic cancer were included. So it is clearly a new step forward, and I don't know if there is a need for competition between FOLFIRINOX and GEM plus nab-paclitaxel. For me, it's two new options for the treatment of our patients, and it's clearly very, very interesting for them. So what could be the next step? It's a little bit more complicated to say. First, I would say that I am not too much surprised about the results of nab-paclitaxel, because there are a lot of literature in the past showing that a combination of gemcitabine plus docetaxel was a little bit active, even if it never did reach clinical significance, statistical clinical significance. But we knew that taxanes could be a little bit interesting in this problem of pancreatic metastatic carcinoma. And new taxanes, such as this other one that has completely disappeared now, which was a cationic liposomal paclitaxel, again showed quite interesting results, potentially interesting results. So the story of nab-paclitaxel is an interesting and completely new and active, and it's a very, very good story for our patients. If we go now into the detail of the other drugs of chemotherapy, and I am surprised on the fact that now when we speak about improvement in the field of pancreatic metastatic carcinoma, we speak a lot about chemotherapy and not too much about targeted therapies. I would like to go into the details of targeted therapies at the end of my talk, but it's very, very surprising that the clear advances have been made with chemotherapy, with cytotoxic agents, and not with targeted therapies in this specific field. So if we look on the problem of chemotherapy and of gemcitabine in pancreatic metastatic carcinoma, there was a hope to get a new gemcitabine, which could be more active than standard gemcitabine, with no need of a specific transporter into the membrane. And that hope was given by this compound, the C0101 agent, which was gemcitabine with a fatty acid tail. But you know that the comparison of this new agent, this new cytotoxic agent, with the old gemcitabine was completely negative, and that now it is not possible to consider this drug for the treatment of our patients, and I think it's a pity. It seems to be very, in terms of rational, it was very, very nice, but with clinical evidence, it failed completely. So we have to continue in that field, and there has been some report on oral prodrug of gemcitabine, which again could be a little bit more active than the standard gemcitabine, but it has been already evaluated with not too much promising agents, and I am not too much confident in that for the future of our patients. Another drug that could be very interesting, but the trial is ongoing at this moment, is this drug. And again, it seems to be very interesting, and again, it is new agent in terms of chemotherapy. It is a drug whose name is the TH302 that is developed by Merck Serono, which seems to be specifically active on cells that are in hypoxia conditions. And it could be very, very interesting in this specific problem of pancreatic carcinoma, because we know that the stroma is very important in this tumor, and that probably chemotherapy does not reach completely the center of the tumor that is completely hypoxic with some sleeping cell, I would say dormant cell, and maybe it's very interesting to evaluate this kind of drug. Phase 2 randomized study was already done with quite promising, I would say, results that are shown on that slide. And there is, at this moment, an ongoing phase 3 trial, the Maestro trial, evaluating gemcitabine plus this agent versus gemcitabine alone. So it could be another option in the future for our patients. But to know that, we have to wait for at least 1.5 years, I would say, or 2 years, maybe, probably. One work in the future, in the horizon, that probably we have to do is to consider now pancreatic carcinoma not only on first line, but to consider it in terms of strategy, because again, we have different options: gemcitabine alone, combination of gemcitabine and nab-paclitaxel, a combination of 5-FU, FOLFIRINOX, or FOLFOX that has been proven to be active in second line. So maybe, as we have done for colorectal cancer, even if there are some work to do on colorectal cancer, it's time to consider the treatment of metastatic pancreatic carcinoma in terms of strategy, of evaluation of first line. What will we do in second line when we will use this first line, and so on. And there are, at this time, 1 or 2 trials evaluating already strategies in the treatment of pancreatic metastatic carcinoma. This one has been done in France. It has been done with, I would say, old regimens. It was gemcitabine followed by LV5-FU2 cisplatin versus the opposite sequence of therapy, LV5-FU2 cisplatin followed by gemcitabine. And it is a little bit disappointing because you can see that the 2 sequences seem to be not different at all. But the idea and the way to develop strategies remains for me very, very interesting. And again, I would like to show a French result. I am not sure that only French people are able to develop something in pancreatic carcinoma. I don't want to say that at all. But again, I think it is interesting. It has been done by Julien Taïeb in France. And the idea of Julien was to try to sequence treatment, not to do a first line followed by a second line, but 2 months of FOLFIRI followed by 2 months of gemcitabine followed by 2 months of FOLFIRI versus continuous treatment with gemcitabine alone. And you can see that the progression-free survival was not too bad in this trial. And I have already at this time a patient that has been treated with the sequential treatment and who is alive more than 2.5 years after the diagnosis. So even if one patient does not give any kind of demonstration, I think it could be kept in mind that some way to sequence the treatment for improvement of median survival for metastatic pancreatic carcinoma is an idea that has to be tested in the future, especially with the new active regimen that we have at this moment. I would like to speak a little bit on targeted therapy, even if it is very, very difficult, because I could say and finish on that, saying that there is nothing on targeted therapies for the treatment of pancreatic metastatic carcinoma, but I think it would be a little bit too short to say that. So what can we say about targeted therapies in the horizon of the treatment of metastatic pancreatic carcinoma? We can at least say that it is difficult. Why it is difficult? It is difficult because, as with chemotherapy, we obtained in the past a lot of hope at the beginning, and then a lot of disappointing results. Combination of gemcitabine plus bevacizumab versus gemcitabine alone, negative. Combination of gemcitabine plus cetuximab versus gemcitabine alone, negative trial. Combination of gemcitabine plus erlotinib versus gemcitabine alone, a little bit better for the combination arm, but a median improvement of median survival of 2 weeks, so a very short improvement in median survival, and so on. Even aflibercept, another anti-angiogenic agent, is negative. It has been published, or it is accepted for publication in European Journal of Cancer. So we remain in a very, very, I would say, difficult problem with this cancer. You can see on this slide the results of gemcitabine plus erlotinib versus gemcitabine alone. The hazard ratio was positive in terms of statistical significance. In terms of clinical significance, it's a little bit more complex, I would say, with a hazard ratio of 0.82. It is the only positive results that I can show you in this global field of addition of targeted therapies to chemotherapy for the treatment of metastatic pancreatic carcinoma. Anti-IGF seem to be, in the past, very interesting, maybe because IGF, it means insulin, so it is in the pancreas, insulin, so it should be good. It should be good, but it does not work. It has been tested in a lot of trials with different compounds of the same family of different laboratories, and completely negative. Even a dual inhibition, which was tested by Philippe, a combination of erlotinib plus cetuximab plus gemcitabine versus gem plus erlotinib, the trial was completely negative. So I think that for this family of antibodies, of agents, the game is over. There remain, or was, considering the numbers, a very high number of targeted therapies that we have, there are always some hope. You can see one of these hope here on the slide with anti-MAC1 and 2 or anti-TGF beta, which have to be tested in pancreatic metastatic carcinoma and maybe could give positive results in the future. An example of another compound, a PARP inhibitor at a very, very early stage. It has been presented during an ASCO meeting. It was a combination of FOLFOX plus this agent, and it has given quite interesting preliminary results in terms of progression-free survival and overall survival, especially in patients with specific mutation of BRCA2. That could be a way to select a specific population for specific treatment with targeted therapy, and probably it is the future of the use of targeted therapy in pancreatic carcinoma, because we know now that if we test and if we use biological therapies as we have tested chemotherapy, we probably will fail. We have first to select a population for new agents, a new targeted therapy, and then to try to evaluate the drug in this specific population. At the end, we have seen at the ASCO meeting some interesting results in non-selected population, as you can see on this slide, with a new anti-EGFR agent. I am not too much confident in that. I am a little bit more confident in these new agents that are presented there, with biomarker analysis that are done concomitantly to the clinical trial, that try to select the population that will be able to benefit more from targeted agents, as it is written on this slide. Another possibility, and we have some work to do, is to add targeted therapies to FOLFIRINOX. It will not be very easy because the level of toxicity of FOLFIRINOX is not too high. I am French, I use it, but it is an active and complex and triplet chemotherapy. So we have to add to FOLFIRINOX not too much aggressive, not too much toxic drugs. TKI for me are completely off, and we cannot add TKI to FOLFIRINOX, but maybe some monoclonal antibody could be added to FOLFIRINOX, and it's a TKI that seems to be possible on this side to be combined with FOLFIRINOX, but I am not too much optimistic in this kind of combination. Just to give you an example on what we maybe can be, it's a quite far horizon, but I have treated a patient that was a neighbor of Jean-Charles Soria in my institution. Jean-Charles Soria is developing a lot of phase 1 studies and personalized medicine. So he sent me these patients. I gave him a combination of chemotherapy with gemcitabine and erlotinib. And after a quite interesting disease growth control period of 12 months, the patient had progression. So he went back to Jean-Charles. I said to Jean-Charles, he is your neighbor. I have done my work. You have to do yours. And there was a first attempt of phase 1 treatment with anti-IGF plus pan-AR inhibitor with a disease control of several months. And then the patient was included in a program of personalized medicine with sequencing, molecular gene analysis, and an active mutation of PI3 kinase was found. And then we treat him with a specific treatment of this mutation. And you can see, even if the patient died, that we were able to obtain a decrease of CA99 in third line with a patient that had a huge tumor mass burden following 2 lines of treatment for pancreatic metastatic carcinoma. So even if it seems to be very complicated to use targeted therapies in the field of pancreatic carcinoma, I think that we have some hope when we consider this kind of story, and it has been published. It's not only a story that I told you this evening. So as a conclusion, I would say that we have made some progresses in the field of pancreatic carcinoma, but it remains a very, very severe disease with a poor median prognosis, a median overall survival, a very poor bad prognosis. And we have to work on sequencing the treatments that are already demonstrated to be active. We have to continue to work, even if we had very, very disappointing results in terms of targeted therapies. We have to continue to work on that, and especially to combine biological evaluation of the patients and then selection of population for targeted therapies. And I think that you can see, you went on clinicaltrials.gov. There are, at this moment, a lot of running trials, and we may hope that there will be a specific and nice horizon for the treatment of metastatic pancreatic cancer. Thank you very much.